Hi everyone, and welcome to our module on chronic leukemias. There are a couple of ways that leukemias can be classified. One way is as myeloid versus lymphoid. If you look at this image on the screen, stem cells in our bone marrow can differentiate into lymphoid progenitors or myeloid progenitors. Lymphoid progenitors go on to produce T cells and B cells. In contrast, myeloid progenitors go on to produce things like platelets, which are thrombocytes, or red blood cells, or granulocytes like neutrophils. So in this video, we'll talk about some leukemias that involve the lymphoid lineage and others that involve the myeloid lineage. Another way to classify leukemias is as acute versus chronic. In another video, I talk about acute leukemias. These have a rapid onset of symptoms, and they involve a specific cell type called blasts seen in the bone marrow. In this video, we're going to focus on chronic leukemias. In general, these leukemias have a slower onset of symptoms, or sometimes no symptoms at all, and the malignant cells are not blasts. They're more mature cells of the myeloid or lymphoid lineage. We'll start by talking about chronic myeloid leukemia, or CML, which is a malignant disorder of myeloid progenitor cells. And in CML, there's excess production from the bone marrow of granulocytes. Granulocytes are white blood cells that have granules in their cytoplasm. This includes basophils, neutrophils, and eosinophils. And although CML is called a leukemia, it's also classified as a myeloproliferative disorder, which are disorders where the bone marrow overproduces one or more cell types. In this case, there's overproduction of granulocytes. In other myeloproliferative disorders that I discuss in other videos, there's overproduction of red cells or platelets. The initial phase of CML is called the chronic phase, and this can last for years, and this is when most patients are initially identified. And in the peripheral blood during the chronic phase of CML, you can first of all see a leukocytosis, so the white blood cell count can get very high. The median count at the time of diagnosis is 100,000. You also see increased numbers of all the granulocytes, so there's an increase in the number of neutrophils. There's also an increase in basophils. This is a very rare finding, and when you see it, you should think of CML. And you can also see an increased number of eosinophils. Besides these things, you also see in the peripheral blood increased numbers of granulocyte precursors. These are cell types that give rise to granulocytes in the bone marrow, and normally you don't see large quantities of them in the peripheral blood, but you do in CML. So you can see increased numbers of myeloblasts, promyelocytes, myelocytes, and band forms. These are all precursors to granulocytes. And so along these lines, a classic finding in CML is called the myelocyte bulge. This means that the number of myelocytes is greater than the number of metamyelocytes. This is a very unusual finding. Usually there are more metamyelocytes seen in the peripheral blood because those are more mature. So this myelocyte bulge with increased numbers of myelocytes is a classic finding of CML. Beyond the white blood cells, you can also see a mild anemia. That's because the bone marrow can underproduce red cells, and there can be normal or increased platelets. If you look down at this table at the bottom right side of the screen, a normal white blood cell count is about 10,000, and normally about 55% of the cells are neutrophils and about 5% are band forms. In the setting of infection, the number of white cells goes up, and also the percentage of white cells that are neutrophils and bands goes up. This is called a leukemoid reaction. It's also called a left shift, and this is a normal response of the body and the blood cells to infection. And so anytime there's an infection, there are going to be more white cells and also more bands and neutrophils, and this has to be distinguished from CML. The major item in the differential diagnosis for chronic myelogenous leukemia is a leukemoid reaction, in other words, a normal response to infection. You have to differentiate that from malignancy. In this setting, bone marrow biopsy is often not very helpful, and that's because in both a leukemoid reaction and CML, the bone marrow has similar findings. There are, however, other clues that you can use to try and distinguish a leukemoid reaction from CML. One is the presence of toxic granulation of neutrophils. This is a neutrophil on the screen here showing toxic granules. These are dark coarse granules, and this is a classic finding seen in the setting of a leukemoid reaction. Also in a leukemoid reaction, the percentage of metamyelocytes should be greater than the myelocytes. In other words, there should be an absence of that myelocyte bulge that we talked about on the last slide. And so then in contrast, when patients have an elevated white count from CML, there will be a myelocyte bulge. And then importantly, in CML, there should be no evidence of infection. Many patients with a leukemoid reaction have an obvious source of infection, but sometimes patients can have an occult infection causing the white blood cell count to climb. And in that setting, you have to use clues like those shown in this slide to distinguish CML from a leukemoid reaction. Another feature you can use to distinguish CML from a leukemoid reaction is called the leukocyte alkaline phosphatase score, or the LAP score. Leukocyte alkaline phosphatase is an enzyme found in normal neutrophils, but it's absent in neutrophils of CML. So you can assess the enzyme level with the LAP score, and it will be low in CML. It will be high in a leukemoid reaction. And years ago, a low LAP score was used to identify cases of CML. In modern practice, this has been mostly replaced by genetic testing for chromosomal abnormalities, and we'll talk about this in a second. But so just to summarize, let's look at this table at the bottom of the screen. So in CML, the LAP score is low, toxic granules are absent, there's a myelocyte bulge, and there's no evidence of an obvious infection. In patients with a leukemoid reaction, in contrast, the LAP score is high, toxic granules are present, there's no myelocyte bulge, and evidence of infection is also apparent. So make sure you know these things on your board exams. They're going to want you to distinguish patients with infection from patients who have CML. The genetic hallmark of CML is called the Philadelphia chromosome. This is the classic genetic abnormality found in malignant cells of chronic myeloid leukemia. It's caused by a translocation of genetic material between chromosomes 9 and 22. If you look at this image on the slide here, what happens is a gene called the ABL gene on chromosome 9 and a gene called the BCR gene on chromosome 22 get switched around so that they're right next to each other. This creates a fusion gene called BCR-ABL, which is abnormal, and it produces an enzyme called a tyrosine kinase. And this enzyme gives myeloid progenitor cells a long cell life, and therefore they accumulate in the bone marrow and they overproduce granulocytes. In terms of clinical features, CML usually affects adults. The median age at diagnosis is about 50 years. And CML begins with a chronic phase that can last many years. That's why it's called chronic myeloid leukemia. During this phase, patients can be asymptomatic. They're sometimes picked up because they have a high white blood cell count on routine testing. Other times, patients can have nonspecific symptoms like fatigue and malaise, weight loss, or splenomegaly. And in the chronic phase, there are always few peripheral blasts. The number of blasts in the periphery is usually less than 2%, and that defines the chronic phase. Eventually, patients can enter what's known as the accelerated phase, which usually lasts months. Clinically, this phase is often identified by treatment failure. We'll talk about how you treat the chronic phase in a minute, but treatment often begins to fail, and there's a rising white blood cell count when patients enter the accelerated phase. And then the accelerated phase can be followed by blast crisis. This is when patients with CML convert to an acute leukemia, and more than 20% of the malignant cells are blasts in the periphery or the bone marrow. Usually they are myeloblasts, so chronic myeloid leukemia essentially converts to AML in the blast crisis phase, but sometimes they can be lymphoblasts, where CML converts to acute lymphoblastic leukemia. So the diagnosis is usually made in the chronic phase. In that phase, patients have a CBC that shows typical CML findings like we talked about earlier, including increased neutrophils and band forms with no evidence of infection or leukemoid reaction. This usually leads to a bone marrow biopsy, which will show granulocyte hyperplasia, and then cytogenetic testing of the malignant cells from the bone marrow biopsy identifies the 922 translocation and the BCR-ABL gene. It's super high yield for your boards to know that the treatment of CML in the chronic phase is with drugs called tyrosine kinase inhibitors. These drugs have names like imatinib, dasatinib, and nilotinib, and they inhibit the tyrosine kinase that results from the Philadelphia chromosome and the BCR-ABL gene. These provide long-term control of CML in the chronic phase, but they're not curative. Basically, they prevent the white blood cell count from climbing and the disease from progressing. Eventually, these drugs will usually fail and patients enter that accelerated phase that we talked about earlier. At that point, more advanced therapies are necessary, like bone marrow transplant. But in the chronic phase, these drugs can be used, and they are oral drugs, and they spare the patient the need for traditional forms of chemotherapy. Okay, moving on, let's talk about chronic lymphocytic leukemia, or CLL. This is a disorder where there's malignant proliferation of B lymphocytes, and this leads to excess circulating lymphocytes and a high peripheral lymphocyte count. The malignant cells of CLL have a characteristic immunophenotype. They are positive for CD5, which is very unusual for B cells. CD5 is normally a T cell marker. But in addition to CD5, they're also positive for traditional B cell markers, including CD20. It's often said that these cells co-express CD20 and CD5, which is very unusual. This is a classic finding in CLL. These cells also express other typical B cell markers like CD19 and CD23. In the video on non-Hodgkin lymphoma, I talk about a form of lymphoma called small lymphocytic lymphoma, or SLL, and you should be aware that this disorder is caused by the same malignant cells as CLL. What distinguishes CLL from SLL is the degree of lymphocytosis, meaning how high the white blood cell count gets. CLL is a leukemia, so there's a high white blood cell count. SLL is a lymphoma, so the white blood cell count is normal or only mildly increased. So by definition, we call the condition SLL if the peripheral lymphocyte count is below 5,000, and we call it CLL if the lymphocyte count is above 5,000. But basically, these two disorders are caused by the same malignant cell. It's just that in one form there are more cells in the peripheral blood. CLL usually affects older adults. The median age at diagnosis is about 70 years. And most patients are asymptomatic. They're identified when a routine CBC finds increased lymphocytes. In a minority of patients, about 5 to 10%, they have B symptoms like fever or sweats. And sometimes there are signs on exam like lymphadenopathy or hepatosplenomegaly. On a peripheral blood smear, the classic finding in CLL is the presence of a smudge cell. This is a smudge cell in the center of the slide here. These are caused because the peripheral lymphocytes in CLL are fragile, and so when you create the blood smear slide, you disrupt the lymphocytes, and this makes the smudge cell. They don't look this way when they're circulating. This is just the way the lymphocytes appear on the slide. In terms of diagnosis, CLL is suspected when the CBC shows a lymphocytosis. And to meet diagnostic criteria, the absolute B lymphocyte count has to be above 5,000 for at least 3 months. In addition, flow cytometry of the peripheral lymphocytes needs to show those markers we talked about earlier on the surface. The majority of the circulating peripheral lymphocytes should express CD5 plus the usual B cell antigens like CD19, 20, or 23. There are a couple of complications of CLL that can occur. The first is cytopenias. So through a number of mechanisms, patients with CLL can sometimes develop neutropenia, anemia, or thrombocytopenia. These things can be present at the time of diagnosis, but usually they're not severe. Also in CLL, there can be hypogammaglobulinemia. So remember that B cells normally produce antibodies, but when patients have CLL, that process can be disrupted. So these patients can have low levels of IgG, IgA, or IgM antibodies. Often one or more antibody levels is decreased. Some patients even have increased levels of antibodies, but they're dysfunctional because the gamma globulins, which make up the antibodies, are abnormal. So what this all means clinically is that patients with CLL are immunocompromised and they have an increased susceptibility to bacterial infections. And then finally, CLL has a well-described association with autoimmune hemolytic anemia, which I talk about in other videos. But in CLL, autoantibodies can develop, and this can lead to hemolysis. You should also be aware that patients with CLL can have their disease transform into diffuse large B-cell lymphoma. I talk about B-cell lymphoma in another video, but remember, the malignant cells in CLL are B cells, and so sometimes they can transform into the cells of diffuse large B-cell lymphoma. The way this classically presents is in a patient who has known CLL and develops rapid growth of a single lymph node. Biopsy of that node will then show diffuse large B-cell lymphoma. In terms of treatment, if patients are asymptomatic, they're usually managed with observation, and this can even be done if the lymphocytosis is extreme. Even if the lymphocyte count is very high, as long as the patient is asymptomatic, often observation is all that's required. Treatment is usually only indicated when certain complications develop, so this includes things like bone marrow failure, or massive splenomegaly, or severe constitutional symptoms. When these things occur, there are a number of treatments that are used. Choosing a specific treatment is a high-level topic, but there are various forms of chemotherapy or antibody-type immunotherapies that can be targeted at the malignant lymphocytes. And that concludes our module on chronic leukemias.